Great. Sorry about the delay, everybody. Good morning. It's nice to meet everybody. I've heard some of you guys on the phone so far, and it's been great working here for the last 7 months. I hope that there's been some improvement in the interventional radiology service. Prof. Keisner, nice to meet you. I just want, it's really great, and thanks for the offer, Cleve, for allowing me to come and have a chat with you. I thought that it would be very good to bring in the cryoablation situation. At the moment, there are cryos being done in Johannesburg as well as in Durban from various interventional radiologists. Interventional radiology in South Africa is in a very, would say it's in a poor state. We're trying to, there's a few guys that are getting trained at the moment, and myself and Dr. Haynes, who's trained with me in Calgary. We are one of the first few to come back, and then Gershwa Human is also just completing his training. Got another 2 guys that are going in July. So I expect interventional radiology to grow within the next 3 to 4 years, with us even moving towards having a fellowship at Hoedskir soon. So that's some exciting stuff. Okay, there we go. Yeah, so just a little bit about the topics for today. We're just going to talk about me and the new skills that we're bringing through at GSH. So a little bit of a swap because I was a little bit late, and I apologize for that. The cryotherapy presentation from Boston to talk about prostate artery embolization, gonadal vein embolization, preoperative embolization for renal cell carcinoma and vascular bone metastases, suprapubic catheters, nephrostomy tubes, and DJ stents. Just a little bit of a background, not going on too long about this, but I just did a fellowship in interventional radiology, as Dr. Oppel described earlier. All right, and this was the cryotherapy section that I was supposed to go through before they came, but we'll start from my side here. So this is just an article that I put together. I don't know if we have somebody's mic is not muted.
Yeah, good morning, everybody that's on the chat. Could everybody kindly mute their microphones? Is it, do I go? Apologies. Here we go. It says pin. Dr. Pariachi, apologies, do you mind muting your microphone?
I think that was a problem. Cool.
Thank you.
Awesome. So image-guided urological interventions, what the urologists must know. So we have percutaneous image-guided interventions that have changed the management of urologic diseases. The applications are growing because of the minimally invasive nature and low procedure-related morbidity and reduced hospital stay. These have evolved from a few diagnostic procedures to the current state-of-the-art therapeutic techniques that include a broad range of non-vascular and vascular applications. Today, they continue to play an important role in drainage procedures, the management of urolithiasis, tumor ablation, and renovascular diseases. There are multiple imaging modalities that are used for this purpose, with fluoroscopic, ultrasound, and digital subtraction angiography being the mainstay. A close multidisciplinary collaboration between urologists, nephrologists, and interventional radiologists is important. So the general principles of vascular and non-vascular interventional radiology and urological management. We'll talk about the vascular cases, for example, embolization of pseudoaneurysms or arteriovenous malformations and fistulas, commonly presenting as hematuria, recanalization and stenting with renal artery stenosis, gonadal vein embolization in varicocele and pelvic congestion syndromes, as well as prostate artery embolization. Non-vascular, we're looking at tissue sampling, whether it be FNA or TrueCut, percutaneous nephrostomies and stone extraction, DJ stent placement, and percutaneous drainage of collections. So just a little bit of an overview on non-vascular. basically we can do it with CT or ultrasound guidance. In this particular case, we're doing an adrenal biopsy, which is indicated when it cannot be characterized by standard imaging or the lesion cannot be characterized by standard imaging or laboratory tests. It can be easily performed using CT or ultrasound guidance. Percutaneous nephrostomies and DJ stenting. So a posterior lateral subcostal approach, which is targeting the lower or middle calyx, which prevents entering through the pleural recess and permits access through Brodal's vascular plane of the kidney. A soft tip wire is then inserted into the collecting system and replaced with a stiff wire using a 6 French dilator. The tract is serially dilated up to 8 to 10 French, and a pigtail catheter or Malacot nephrostomy tube is then placed in the renal pelvis. The latter is a better choice if the collecting system is either small or filled with calculi. PCN has a high success rate, approaching 100% in dilated systems and around 80% in undilated systems. Complications include bleeding, infection, and injury to adjacent organs, although rare. The placement of DJ stents can be done in the same setting if the bladder primary is excluded, and the current preference of stents is the Cook-Amplatzer DJ stent, which has strings at the proximal aspect, and this allows increased control when deploying. Tumor stents can be deployed upon request. So suprapubic catheters, insertions, and exchanges are now mostly done in the trauma setting and can be done if the bladder is quite distended and pretty easily done, but we are available if it is a complicated procedure and you guys need a bit of help. So it can be inserted on an ultrasound guided or even fluoroscopy guided in a contrasted pacified urinary bladder. So with regards to vascular interventions, so the endovascular embolizations are minimally invasive procedures where the lumen of the intrarenal vessel is occluded by embolizing material. The indications include persistent hematuria due to pseudoaneurysms, etc., arteriovenous fistulas following biopsy, surgical or accidental trauma are also other indications. Supraselective embolization of the feeding artery saves more functioning nephrons than conventional surgery. It is also employed to reduce the vascularity of renal tumors, for example, angiomyolipoma, like I did yesterday, as well as renal cell carcinoma prior to surgery. I'm not sure whether that had any effect. I did a renal cell carcinoma. I think, Prof, were you involved in the case? Did it help? Hey, not much bleeding. That's good. It's good to hear. Oh, that's great. Yeah, so we can use gel foam, we can use vascular coils, and which are the usual materials used for this purpose. The procedure has a success rate of around 90% and has a few complications, although rare. We also offer transjugular renal biopsies. So we also, to the hepatologists, we offer transjugular liver biopsies. I don't know how much of a urological application this is, but we are able to take biopsies of the kidney in patients who have contraindication to percutaneous biopsy. So if you can share that with your colleagues, it will be great. Gonadal vein embolization performed in males with scrotal varicocele causing pain and infertility, and in women for pelvic congestion syndrome as a result of retrograde flow and incompetent ovarian veins, causing chronic pelvic pain. The veins are approached via jugular or femoral route. After diagnostic angiography, the veins are embolized using steel coils and sclerosing material, in particular sodium tetradecyl sulfate, which is called STS. The clinical outcomes of technically successful percutaneous internal spermatic vein embolization are similar to surgical treatment. Recanalization of renal artery stenosis. So renal artery stenosis is found in 2% to 40% of the general and high cardiovascular risk populations, respectively. Recanalization involves balloon angioplasty and or stenting of hemodynamically significant renal artery stenosis as defined by transstenotic pressure of greater than 20 millimeters of mercury. The renal artery is approached via the transfemoral route, and preliminary diagnostic angiography defines the site of stenosis, which is crossed using a guide wire, and balloon angioplasty is then done, plus minus stenting. The technical success depends on the site of the stenosis and underlying etiology. It ranges from 40% in osteoatherosclerosis to 90% in FMD. Stenting coupled with angioplasty has a higher success rate. The procedure, however, is associated with significant risk of complications. Lately, there's been a marked decline in the number of these recanalization procedures done worldwide. This is a result of recently published trials which have showed not shown any benefit to renal revascularization over medical therapy for blood pressure control. However, it is agreed that selected high-risk patients who have severe or refractory hypertension, heart failure, or rapid loss of renal function may benefit from this procedure. Recent advances, as described by our colleagues from Boston, I'm not going to go too far into it, but the RFA and cryoablation have been the best studied recent advances in local treatment for renal cell carcinomas in patients unsuitable for surgery. Patients having renal insufficiency at the time of presentation and tumors requiring a more nephron-conserving approach, for example, solitary kidney, multiple synchronous RCCs, vulnerable Lindau, familial RCC are also candidates for these minimally ablasive techniques. In the short term, 90 to 95% of the control rates are achieved, with 6% significant complication rates are seen for tumors less than 3 centimeters for both techniques. The major limitations for both of these techniques, or the lack of these techniques, are the lack of prospective randomized clinical trials or long-term follow-up data. The meta-analysis of 46 series compared results of surgical and percutaneous treatment of renal tumors. The analysis showed the significantly lower primary effectiveness rate for the percutaneous group as compared to the surgical group. There's no significant difference in the retreatment rates. The major complication rate was significantly lower, however, in the percutaneous treatment group than the surgical group. So microwave ablation has the potential advantages of being able to treat cystic renal tumors, but has even lesser data, as we've described in the previous discussion. Other recent advances were our prostate artery embolization. So new, not so new, but minimally invasive endovascular technique to treat lower urinary tract symptoms due to benign prostatic hypertrophy. It has been used in patients with renal cell, with prostatic CA as well, very sporadically. It is undertaken in a few centers, especially with prostates who are over 80 grams, who are refractory to medication or higher risk for surgery, performed under local anesthesia and as an outpatient procedure with low morbidity and rapid recovery. The prostate arteries, which arise from the anterior division of the internal iliac artery, are both super selectively catheterized and followed with a slow injection of dilute embolic agents, which could be PVA-sized PVA particles, which are pretty small, 100 to 200 microns, and gelatin microspheres have also been used. The endpoint is identified by near stasis of the flow of the injected arteries and gland opacification. Preliminary data have shown that it relieves symptoms, improves quality of life, preserves sexual function in the short and medium-term follow-up, and may therefore be seen as an effective alternative to surgery. Thanks.
Thank you very much, Dale, for that talk this morning. Do we have any questions from the floor? Nobody?
You should never offer to take on a super big catheter service.
Yeah, it's dangerous ground. Yeah, that might be abused. Dale, just a question on the prosthetic artery embolization. So as far as we have it, I mean, according to our sort of guidelines, TURP and open prostatectomy are still sort of the gold standard. Emerging things are other forms of enucleation, like HOLIP and that sort of thing. And then they sort of push PAE down for, the not fit guy can't tolerate a GA or any form of severe blood loss or something like that in theater. Is there any specific, the patients that do they need to be fit, healthy, young, or, just be able to lay sort of supine for a period of time to be able to receive that sort of form of treatment?
Yeah, so I spent some time with a clinical radiologist that was trained in the UK. He's based in Durban. His name is Gareth Bidewell. I spent some time with him just to see, because from my experience in Canada, it was very much an older population.
Okay.
And, the ones that were definitely the risk, the ones that were high risk for surgery. But now spending time within South Africa and seeing how it's in a high volume center that Gareth Butterwell has at Lakesmith and Partners. Patients are very minimally sedated, quite elderly, both dose upon their own. It's quite a nice procedure for them. It goes pretty well, and they're sent home on the same day. And it's quite a funny story because there was one particular gentleman that was there, and he came from one of these peripheral towns in KZN, and he had the embolization and went back and told all his old friends about it, and they all started coming for the same procedure because it helped him so much.
Yeah.
It kind of spreads like a lot of patients. Sometimes in the private sector, it is a patient choice thing, and it has been proven to be effective. But however, it's still in the hands of the urologist.
Yes, yeah. I think one of our biggest concerns is the sort of surrounding organ. I mean, that's what we read about. You can get a degree of proctitis, ischemic proctitis, or ischemic, depending on, because the vasculature is quite difficult, I would assume, to target that specific vessel. We find that not
usually when I have these older men with atherosclerotic, they're quite little, little things, it's very difficult to get into. That's why you need to have the technology. You have to have cone beam CT at your disposal. So cone beam CT is where we actually pop the catheter inside the blood vessel that we suspected to be the prostate artery, and then we will have, obviously, you can have the catheter inside, which helps a bit of a localization of where the prostate would be. Then we do a pump injected spin. So the angio, the X-ray machine spins around like a CT machine would do. And then what that does is it will create it's not a really great picture, but it helps us with the pump injection to see the classification of the prostate.
Yeah.
So we are able to identify the prostate artery itself, and the fact that it's going directly to the prostate. There's no penile coming in, etc. But we do have evasive techniques to get past that to stop. There has been noted complications where, in prostate artery embolization, when the penile comes up, that sometimes it's embolized and there are other complications that come with that. But there are ways with training that can avoid that.
I mean, it's quite exciting if we start this to get a series going and see what our outcomes are looking like. And then with regards to the varicoceles, again, very, very intriguing. We see them. We do see them. Is there any data on sort of performing sort of sclerotherapy embolization after a failed surgical varicocelectomy? If they are still aberrants or something like that?
I think it really comes down to access.
Yeah.
So it depends what surgery you've done and how, if you've taken off the main gonadal and our access is now compromised, we have to find sort of these side routes that have now been created. It can be quite difficult.
Yeah, then it's a bit challenging, eh?
Yeah.
Do you have any other questions?
Just a question about radiography in people leaving. So just kind of interested about the difference in sensitivity between a CTA and angio. Because I think what tends to happen when these patients that bleed, and then you kind of almost when you do CTA and they still bleed and you're like, what's happening here? And I've always thought that if somebody is sick enough to warrant investigation, then they warrant intervention as well. So what happens is then you do the CTA and then they have an angio. I always wondered because I think that there is a slight discrepancy in sensitivity between the two of them.
No, so probably
Why is that?
the CT angiogram is the gold standard by far when it comes to
a normal angio.
So the risks of you want to always go non-invasive first. There's a risk of going and doing it DSA in a patient who doesn't have anything.
Yeah.
And then causing that, the risk of dissection, etc. is so small. But you want to try and get to the point that you are treating, the CT angiogram is such a great, our new CT system, the way the pump injectors work, the sensitivity is extremely high. So I don't think that it's to move to DSA directly, it's not necessary.
So you often have those oaks that come in. The biggest problem we have is those oaks that come in, it's always an oak which will play. You've had a delay in which they bleed like a stick. And then those are the problems. The other ones, they come and they're like, bleed a bit and they're all good on.
From that trauma, from
Trauma.
No, trauma. So it's like going up the stairs. So they come with an ambulance, like, or whatever, or they come with an acute, usually it's a acute anesthesia, but it's actually kind of a secondary invasion. They got renal colic, and the toxin, the ureter, the transfuse, and then, but some of them are proper sick, and then you kind of, it's a bit of an issue to, but then they need, and often they need a bit of renal dysfunction because of the pituitary construction, they need to see the nerve and bleeding down to 8 to 5. It's always problematic for the patients because then first you have to go to CT, and then you have to go and then sort of for a and then they're a problematic group,
So in that particular case, like the both patients had a stab, for example, and obviously going to be a region of kidney damage, right? You guys clinically are seeing cases of hematuria. They may not be present on the CT, maybe at that particular time there was clots and the bleed, etc. Maybe the delayed phase wasn't done properly, and you're not seeing the constitution, whatever the process may be. But clinically, in that particular case, there is indication to take out that particular segment of the kidney, counseling that has been done. So, but we still need a CT prior to that to know this. So that's the only thing. So I'm pretty sure they would have. I mean, the patient needs to step blank with hematuria, they're going to get a CT angiogram done. Even if there's no active sterilization, if there's an injury to the kidney, we are happy to go and embolize that particular.
And those guys are very problem group for us. They often they don't really come with imaging permissions playing, do some kinds of cities that they get their operators in this phases and
I think don't hesitate in that particular case. You guys, so it's very much the clinicians in charge. If you guys have suspicion and the feeling that it's probably going to be not in a state on CT, but if make sure that the patient is not stable, needs to be done. Okay.
That's very encouraging. Thank you, Dan. Tommaso?
Yeah, I am right. Yeah. However, just a more to see also if you propose the retrograde approach. Wanted to know if you have also experience with the unretrograde approach in the our procedure, and if so, how you decide to use the one or the other.
I don't have any experience with the red approach. My approach is really traditional. It's dependent on access to the enough for the easier to work on. So that for me is
now essentially is certified patient and according to Interventional the retrograde approach for grade 4 or grade 5 application, and instead grade 1 to grade 3 we treat ourselves with a proper procedure.
Oh, okay. So is it any likely, I'm not sure what that procedure is that an ultrasound guided sclerosing of the brackets so that you guys do is that what it is?
Yeah, well, we do modify our procedures when we cannulate one of the vein directly to the dentist. We do a fluoroscopy control to check if really the male for the lesson, and we do some sterile solution.
So that's, I mean, obviously under ultrasound guidance, there's pretty good hands there to get into those small veins. Okay, that's cool. Thank you.
And then Dale, maybe just one lot. It wasn't mentioned on your offering there, but high flow priapism. I know we can offer embolization. It's not a very common thing seen, but it's a bit awkward to send a reassure patient, nothing's going to happen, you're fine, but send them home. Do you? They talk about you can give absorbable embolization material. Do you think that's something we'd be able to offer if we have a case like that?
So my experience is limited with them. However, I've been involved with quite a few presentations. In fact, Gershwin Human has gone to Montreal. They are very much a center that deals with that, with those particular types of problems. And I can lean on his advice there. I do know how the procedure is done.
Yeah.
I've just never done them.
Yeah.
And I think that we can always look at trying.
I think that's I think again, discuss with the patient and see if everybody's happy. All right, are there any further questions for Dr. Creamer this morning?
No, but he's not asking me.
He's got an internet connection issue. Then without any further questions, Dale, we'd just like to thank you for your time this morning. It was a very exciting, engaging discussion. I think everybody learned quite a bit today, and it's very refreshing to have somebody with your enthusiasm join the radiology and specific body interventional radiology department. I think we will collaborate quite well going forward, and I think it's going to be with great benefit to the patients that we see. So thank you very much.
Thank you, everyone.
All right. All right. All right, everybody. Have a good